Today, we're embarking on a mission to decode one of the most primal, universal, and, frankly, deeply unpleasant experiences the human body can generate: nausea.
And of course, the act of vomiting that often follows.
Exactly. It's the body's ultimate eject button, right?
Yeah.
An ancient defense mechanism that's designed to save us from ingesting poison.
And when that mechanism gets triggered unnecessarily, whether it's by motion, chemotherapy, or, an underlying disease, it becomes debilitating. We are diving into a comprehensive stack of sources covering the pharmacology of gastrointestinal regulation
We're going to be dissecting the nervous system pathways.
and systematically breaking down the pharmacological tools used to control them.
Our goal for you, the listener, is to gain a structured, really thorough understanding of the why and the how behind these medications: antiemetic, prokinetic, and digestant drugs.
Right.
We don't just want to know the drug name. We want to pinpoint the precise receptor actions that make each drug class unique. If you know the receptor, you know the drug.
You know the pathway and you know the target. That's our mission today.
That core principle, if you know the receptor, you know the drug, it feels absolutely critical here.
It is. Controlling emesis or vomiting is far from a simple signal blocking problem. If we connect this to the bigger picture, emesis is a process where a multitude of different incoming signals, these afferent pathways, all converge onto the brainstem.
A central hub.
A central hub, exactly. So treating it effectively, especially in these severe scenarios like chemotherapy-induced nausea, it requires specialized agents that can block those specific, unique inputs. If you only block one pathway,
You're only solving one part of the problem.
that's it. The body will just use another route to signal that same distress.
Okay, let's unpack this then. Before we can safely disable the eject button, we have to understand the circuitry. What tells the body to even start the process? Where is the main headquarters for this complex involuntary action?
The main headquarters, the core center of this entire operation, is the vomiting center. We can just call it the VC.
The VC. Okay.
And this center is located deep within the brainstem in the medulla oblongata. So vomiting is just the physical manifestation of the stimulation of this VC.
But it doesn't act alone, right?
Critically, no, it never acts in isolation. It works hand in hand with something called the nucleus tractus solitarius, or the NTS.
NTS, got it.
Our sources confirm that the VC and the NTS together are the most important relay areas for all the afferent impulses, all those treadle signals coming from every corner of the body: the GI tract, the throat, other viscera.
So you can think of the VC as the commander.
And the NTS as the central intelligence hub, the place that's collecting all the alarming data.
So the NTS is like the clearinghouse for all these distress signals. But if the VC is the CEO of the vomiting response, it needs a way to detect immediate system-wide chemical threats. I'm talking about things circulating in the blood.
Exactly.
And that brings us to what I think is the most fascinating and frankly terrifying part of the brainstem. The chemoreceptor trigger zone, the CTZ.
Yes. And what's truly revolutionary about the CTZ is its location. It's in a spot called the area postrema. And its critical function as a toxic checkpoint is ensured because it is structurally unprotected by the blood-brain barrier.
It's outside the shield.
It sits right outside that protective shield. And that means drugs, hormones, mediators, and most importantly, circulating toxins have direct, immediate access to it. They don't have to fight their way through a membrane. They just signal trouble the moment they enter circulation.
That's a massive evolutionary trade-off, isn't it?
It is.
The body sacrifices brain protection, specifically at that one spot. It's like putting a highly sensitive landmine right outside the main bunker door.
It is. Toxin detection is prioritized over absolute safety because that quick detection of a blood-borne poison is, well, it's life-saving.
It allows for an immediate response.
Precisely. Now, when the body senses a toxin, particularly in the gut, which, is this huge source of information, how does that signal get from the GI tract all the way up to those central relay stations?
It all starts with damage.
That's right. The primary mechanism involves the neurotransmitter serotonin, or 5-HT. When irritants, like the ones from cytotoxic chemotherapy drugs or radiation, cause damage to the gut lining, they trigger a massive release of 5-HT.
From where?
From specialized cells called enterochromaffin cells in the gut wall. This is the initial alarm.
And what happens once that 5-HT is released?
This released 5-HT then acts on 5-HT3 receptors, which are densely packed on the primary afferent neurons of the enteric nervous system, the ENS.
The second brain.
The second brain, exactly. The ENS senses this local overload of serotonin and just fires off the distress signal. These excited neurons then connect up through vagal and spinal afferents to send their impulses straight to the NTS and the CTZ. The alarm has now reached central command.
And to make matters worse, it seems like there's a redundancy in the signaling. The 5-HT doesn't just act locally in the gut, does it?
Absolutely not. To compound the problem, a large amount of that released 5-HT can also spill into the circulation. And since the CTZ is unprotected by the BBB,
The circulating 5-HT can just get right to it.
it reaches the CTZ via the vascular route, reinforcing the central signal that something needs to be expelled. This dual signaling local activation of the nerves and central activation of the CTZ is why 5-HT is such a massive player in chemically induced vomiting.
And it's why modern antiemetics focus almost exclusively on blocking that specific receptor.
Exactly. But as you noted earlier, it's not a single pathway problem. It's a whole bunch of converging pathways. So beyond 5-HT, what other key mediators are sending these distress signals?
Right. What else do we need to worry about?
Well, while 5-HT is the main villain for chemo-induced nausea, the CTZ and NTS are covered in a variety of other receptors. We're talking about substance P, which activates the neurokinin or NK1 receptors.
I think K1.
Various peptides like cholecystokinin, histamine H1, dopamine D2, cholinergic muscarinic or M, and even cannabinoid CB receptors.
Wow, that list is almost overwhelming. It proves that the body has incredible backup systems for defense if you block the 5-HT3 receptor.
The toxin might still activate the NK1 receptor, and the vomiting response continues.
The sheer number of targets really explains the complexity of high-level treatment.
It does. Now, shifting away from bloodborne toxins and the gut, there is a second major pathway that triggers vomiting. This one is particularly relevant when we're in a car or a boat or on a fairground ride.
Motion sickness, the inner ear. The sensory system is just confused.
The inner ear, or the vestibular apparatus, is entirely responsible for motion sickness. When the head is rotated or disturbed, or when there's a mismatch between what you see and what your inner ear feels, impulses are generated.
And they travel where?
Directly to the vomiting center. And crucially, the sources point out that these impulses use very specific receptors, muscarinic or M, as well as H1 receptors.
This distinction is golden, and we need to lock it into our memory right now.
Yes.
The chemical or gut pathway relies heavily on 5-HT3 and D2 receptors, while the motion sickness pathway relies on M and H1 receptors. This difference in primary targets is the fundamental reason why the classification of antiemetic drugs is so precise.
It is the absolute foundation of clinical decision-making. Now, before the actual physical act of emesis, the body prepares itself. What happens physiologically when that nausea sets in?
You feel generally miserable, sweaty, and your stomach just stops working.
That's the feeling, and the physiology matches it. Nausea is accompanied by a significant reduction in gastric tone and peristalsis. It's essentially slowing the GI tract down. It's called stasis.
The body is halting the forward movement of whatever it thinks is a toxin.
Exactly. Then, when the emetic response is fully triggered, the body initiates this highly coordinated and violent physical act.
This is where the plumbing gets involved.
Indeed. It involves the critical relaxation of several sphincters, the esophagus, the cardia at the entrance to the stomach, and the glottis to open the exit path and protect the airway.
And then the contractions begin.
Then the rhythmic, forceful contractions begin. The diaphragm and the abdominal muscles compress the stomach. This massive, sudden increase in pressure forcibly expels the stomach contents. It's a highly efficient process aimed at rapid evacuation.
Now, we make that dramatic pivot. In some urgent scenarios, the goal is not to stop the vomiting reflex, but to start it intentionally.
Yeah.
Usually in response to a suspected acute poisoning,
Right.
we are forcing the eject button.
Right.
So what are the main emetic agents detailed in our sources, and how do they differ pharmacologically?
Historically, we have two primary pharmaceutical agents, apomorphine and ipecacuanha.
KD.
And although the use of induced vomiting has largely been replaced by things like gastric lavage and activated charcoal in modern ERs, understanding these agents really explains the mechanisms of the CTZ and the VC.
Let's start with apomorphine. It sounds like a nervous system agent, just from the morphine in the name.
It is a semi-synthetic derivative of morphine. However, its emetic action is entirely distinct from its narcotic properties. It acts powerfully and rapidly as a dopaminergic agonist.
So it stimulates dopamine receptors.
Specifically, it stimulates the D2 receptors located directly on the CTZ. And remember, the CTZ sits outside the blood-brain barrier, so apomorphine acts rapidly when it's injected. You usually see an effect within a blistering 3 to 6 minutes. It is the fastest emetic available.
That speed and reliability sound compelling for an emergency. So what are the major physiological downsides that limit its usage now?
Its main limitation comes from its inherent nature as a morphine derivative. It has strong respiratory and CNS depressant actions. So while it was historically noted to have some therapeutic use in
It's
Parkinsonism,
not used for that today.
no, not really, due to these profound CNS complications. The risk of the patient suffering respiratory failure or severe sedation right after vomiting, that far outweighs the benefit in many poison cases.
So high efficiency but high risk. Okay, now let's consider ipecacuanha, the traditional household remedy that many of us grew up with.
Syrup ipecac contains the active substance emmetine. This agent has a dual action, which makes it safer but less efficient.
How does it work?
It works in part by directly irritating the gastric mucosa, a localized effect, and in part through stimulating the CTZ. Because it's generally safer than parenteral apomorphine, it was historically very popular as a household remedy.
And what's the trade-off in effectiveness?
It is less dependable and much, much slower. You typically wait 15 minutes or more to produce an effect. Sometimes you need a second dose, or it can even fail entirely.
And that delay can be critical.
It can when you're treating an acute poisoning. Hence, the general shift away from these chemical emetics towards procedures like gastric lavage in professional settings.
So we have a fast, high-risk option in apomorphine and a slower, safer, but less reliable option in ipecacuanha. But regardless of which one you use, this leads us to a crucial segment. The critical times when inducing vomiting is absolutely contraindicated, when the cure is, quite literally, worse than the poisoning.
This is a point of absolute clinical distinction, non-negotiable safety. Our sources list 5 specific contraindications that must be remembered. First, and arguably the most dangerous, corrosive poisoning.
Poisoning by strong acid or alkali.
Yes, and the reason is mechanical.
It's catastrophic, right?
Completely. If you induce vomiting, the corrosive fluid causes perforation and further severe injury to the already damaged esophageal and gastric mucosa on its way back up.
You are essentially burning the GI tract a second time.
You're multiplying the damage. The treatment here requires dilution and protection, not expulsion.
What about drug-related poisonings, where the patient's stability is already compromised?
Second, avoid emetics in CNS stimulant drug poisoning. The action of vomiting itself, the physical exertion, the stress, it may precipitate potentially fatal convulsions in these already highly stimulated patients. It makes the situation far more dangerous.
And there's a mechanical risk specific to certain types of ingested substances.
Yes. Third, kerosene or petroleum poisoning is a major concern. Because this liquid has exceptionally low viscosity, there is a prohibitively high risk of aspiration.
Meaning it gets into the lungs.
And that leads to severe and potentially fatal chemical pneumonia. Trying to force it out almost guarantees aspiration.
That's a powerful lesson. The physical properties of the ingested poison have to dictate the response.
Absolutely.
What about the patient's consciousness level? This seems like a simple common sense rule.
Fourth, inducing vomiting in an unconscious patient is unequivocally contraindicated because they may aspirate the vomit. The laryngeal reflex, which normally protects the airway, is likely impaired or just absent.
Increasing the risk of aspiration pneumonia. You can't safely force someone to vomit if they can't protect their own airway.
You can't. And finally, fifth, emetics may just fail to act in poisoning caused by drugs that already depress the central nervous system, like morphine or phenothiazines. The depressed state may render the VC or CTZ unresponsive, making the effort futile and just delaying effective life-saving treatment. Having reviewed the dangers of intentionally inducing vomiting, we now shift our focus entirely to defense. Antiemetic drugs. This is the main arsenal. These are drugs designed to prevent or suppress vomiting by strategically blocking the various receptors and pathways we outlined in Section 1.
This is where our adherence to the if you know the receptor, you know the drug principle truly pays off. Let's review the map. We're going to systematically cover anticholinergics, H1 antihistaminics, neuroleptics, prokinetics, 5-HT3 antagonists, NK1 receptor antagonists, and adjuvant agents. It's a vast and sophisticated toolbox.
And the choice of tool depends entirely on the root cause of the nausea.
If the issue is motion sickness, that confusion from the inner ear, the signal is mediated by muscarinic M and H1 receptors. So we start with the drugs that block these specific targets, beginning with the anticholinergics.
The prototype and one of the most effective agents for motion sickness is hyoscine, also known as scopolamine. It is extremely effective, especially for prophylaxis of short, brisk journeys.
And its mechanism is just razor sharp.
It is. It blocks the cholinergic link in the pathway that originates from the vestibular apparatus and heads toward the vomiting center. It cuts the wire between the confused inner ear and the VC.
The sources highlighted a classic issue with this drug side effects and short duration, but also a brilliant solution: the transdermal patch.
That's correct. Oral hyoscine typically has a short duration and causes pretty pronounced anticholinergic side effects like dry mouth and blurred vision. To overcome this, the transdermal patch was engineered. A single 1.5 milligram patch can provide a controlled, sustained dose, offering protection over 3 full days.
So you get continuous prophylaxis without the constant redosing.
Exactly. We also have dicyclamine, mentioned for both motion sickness and morning sickness, though our sources make a clear note of the potential teratogenic risk during pregnancy, which is a significant clinical caution.
Moving to H1 antihistaminics, these are also essential frontline agents for motion sickness. Their antiemetic property isn't a single action, is it? It's more complex.
It's a multi-pronged approach. Their antiemetic action is essentially a triple threat, combining antihistamic activity, some weak antidopaminergic action, and most notably, strong sedative properties.
So drugs like promethazine, diphenhydramine.
And dimenhydrinate. They offer excellent protection for motion sickness, generally lasting 4 to 6 hours. They work by blocking those central H1 and M receptors in the vestibular pathway.
But the downside of these older first-generation antihistamines is a major quality of life compromise that marked sedation and dry mouth.
Absolutely. The sedation is so pronounced that our sources explicitly warn that driving is strongly discouraged after taking these drugs. Essentially, to avoid motion sickness, you often have to trade your ability to drive or think clearly.
Let's pause on a specific demographic: women suffering from morning sickness, the vomiting of early pregnancy.
Doxylamine is the key agent here. It's a sedative H1 antihistaminic known for its prominent anticholinergic activity. It is frequently marketed in combination with pyridoxine or vitamin B6 for managing hyperemesis gravidarum. It's effective, but we have to emphasize that while it's widely used in many places, its use is not universal. The UK and many other countries, for example, have different guidelines.
Right. And we should also mention the agents designed to offer protection without such heavy sedation.
That brings us to meclizine, which is significantly less sedative, less anticholinergic, and boasts a much longer duration of action. It's effective against seasickness for nearly 24 hours.
And then there's cinnarizine.
Cinnarizine, yes. It's classified primarily as an anti-vertigo drug, but it possesses antiemetic properties, and it has a very specific mechanism.
Targeting calcium, if I recall correctly.
That's right. It operates by inhibiting the influx of calcium ions from the endolymph into the vestibular sensory cells. This precise action helps to stabilize and mediate those labyrinthine reflexes, effectively calming the inner ear signals at the cellular level.
So the core takeaway for motion sickness prophylaxis is clear. The pathway is M and H1, and the solutions are anticholinergics and first-generation H1 antihistamines.
And critically, they must be taken prophylactically 30 minutes to 1 hour before the journey begins.
We now move away from the highly targeted vestibular pathway and into broader suppression. These are the older neuroleptics, or D2 blockers.
Yes, and these are potent antiemetics and sedatives, acting primarily by blocking D2 receptors in the CTZ. Their secondary action involves blocking H1 and muscarinic receptors, which gives them a very wide, nonspecific spectrum of antiemetic action against multiple causes.
This sounds like a sledgehammer approach. When is this broad spectrum needed?
When the cause is diffuse, nonspecific, or severe. Things like postoperative nausea and vomiting, or disease-induced vomiting like in uremia or gastroenteritis, radiation sickness, or even hyperemesis gravidarum.
But the sources included a stark warning about their general use.
A critical warning. These drugs should generally not be used except in specific resistant cases like hyperemesis gravidarum if other safer agents have failed because of the significant risks of serious side effects.
What's the representative drug here, and what is the primary side effect risk?
Prochlorperazine, or CPZ, is the key example. It's a D2 blocking phenothiazine. It's a strong antiemetic and a mild sedative, but its primary limitation is the high potential for extrapyramidal side effects, EPS.
Involuntary movements, tremors, severe muscle spasms.
All of that. And I remember reading that dystonic reactions are particularly common in children treated with CPZ. That's a major point of caution.
It is. The D2 blockade in the CTZ that makes them effective also carries the risk of disrupting dopamine pathways in the basal ganglia, leading to these debilitating motor side effects. This risk severely limits their widespread utility.
And it drove the need for D2 blockers that don't cross the blood-brain barrier effectively, which brings us perfectly to our next class.
This class represents a sophisticated approach. Prokinetics tackle vomiting by addressing the physical mechanics. They aren't just blocking a signal, they are enhancing GI motility, speeding up the plumbing by clearing out the stomach.
That is the essence of prokinetics. They enhance coordinated propulsive motility. If you have a slow traffic jam in the stomach-delayed gastric emptying, these drugs act as the police escort to clear the way. They are crucial for treating vomiting that stems from physical stasis and conditions like dyspepsia or gastroparesis.
Let's start with the classic example, the hybrid agent, metoclopramide or Reglan. How does this drug manage to be a prokinetic and an antiemetic at the same time?
Metoclopramide is a substituted benzamide with a true dual mechanism. Its primary antiemetic action is central. It comes from D2 antagonism in the CTZ, just like the neuroleptics we just discussed.
And that's why it can cause similar CNS side effects like sedation and EPS?
Exactly, particularly at higher doses. But its GI action is what truly sets it apart from the neuroleptics. Here's where it gets really interesting.
Okay.
Its prokinetic action is a combination play. It acts as a weak 5-HT3 blocker and, crucially, a 5-HT4 agonist.
So it stimulates 5-HT4.
And that 5-HT4 agonism is the key to motility. It enhances the release of acetylcholine, or 8, from myenteric motor neurons. HE is the main signaling molecule for GI movement. This stimulated H then increases the tone of the lower esophageal sphincter, preventing reflux, while simultaneously relaxing the pylorus and duodenum, promoting smooth, fast gastric emptying.
So it's a powerhouse. It's clearing the plumbing and blocking the central alarm at the CTZ. What are its core uses?
It's widely used as an effective antiemetic, often combined with other agents for CINV, and it is a mainstay for treating gastroparesis and milder cases of GERD. The trade-off, however, remains its central D2 blockade.
Moving to domperidone, this drug offers a significant improvement in the safety profile compared to metoclopramide, purely based on its pharmacokinetics.
Domperidone is also a D2 receptor antagonist, but it has a crucial pharmacological advantage. It crosses the blood-brain barrier very poorly. Therefore, its central D2 blockade is limited almost exclusively to the CTZ, which is outside the BBB. And that means significantly fewer extrapyramidal side effects occur.
So its action is almost purely peripheral, targeting the GI tract and the unprotected CTZ.
That's right. It increases LES tone and promotes gastric emptying without heavily drugging the central nervous system. It's ideal for postoperative nausea, dyspepsia, and diabetic gastroparesis.
But there's a catch.
A critical distinction remains. Because its action is localized and lacks that systemic D2 power, it is not effective in severe CINV or motion sickness.
This brings us to a crucial and frankly terrifying historical chapter in GI pharmacology. The rise and fall of cisapride and the life-saving lesson it taught us about drug metabolism.
This is a textbook example of unintended consequences. Cisapride was introduced as the next big thing. It was primarily a 5-HT4 agonist and a 5-HT3 antagonist. Crucially, it did not block D2 receptors, so it completely avoided the EPS seen with metoclopramide.
Superior GI action with an excellent CNS safety profile. The perfect prokinetic.
Or so it seemed. But the sources highlight the major unexpected problem, which was entirely cardiac. The devastating side effect was cardiac toxicity. Cisapride caused QT interval prolongation.
Which is the time it takes for the heart's ventricles to recharge between beats.
Right, and when this is prolonged, it creates a risk of a serious, often fatal ventricular arrhythmia called torsades de pointe.
And this wasn't just a risk on its own, it was amplified by specific drug interactions, which is the heart of the cisapride disaster.
Exactly. Cisapride is primarily metabolized by a critical liver enzyme called CYP3A4. If a patient took cisapride alongside common medications that inhibit CYP3A4, like certain antifungals, or macrolide antibiotics like erythromycin, the body couldn't break cisapride down. The drug's plasma levels skyrocketed to toxic concentrations.
Virtually guaranteeing QT prolongation and the risk of fatal arrhythmia.
That's it. This drug interaction dramatically increased the risk of sudden cardiac death. Because of these serious, unexpected safety concerns, cisapride was withdrawn in the U.S. in 2000 and its use severely restricted globally. It stands as a profound lesson.
So what agent succeeded cisapride, managing the prokinetic action while meticulously avoiding that critical cardiac risk?
Several agents were developed with improved safety profiles. Mosapride was designed to retain the prokinetic efficacy, but was found to have minimal affinity for HERG channels, the specific ion channels associated with QT prolongation. It has a low affinity for cardiac receptors, making it much safer.
Then there is idapride, which introduces a slightly different mechanism.
Idapride, another substituted benzamide, has a dual mechanism. It's a D2 antagonist and a cholinesterase inhibitor. By inhibiting She, it increases local ACE levels, further boosting motility. Importantly, like mosapride, it has a low affinity for cardiac receptors and avoids clinically significant interactions with that dangerous CYP3A4 pathway.
Finally, we have cinedopride.
Cinedopride is another benzamide GI stimulant. It has complex activity inhibiting 5-HT, stimulating D2 receptors, stimulating 5-HT2 receptors. While it's indicated for GI disorders like delayed gastric emptying and GER, our sources do note that the clinical data on its comparative efficacy remains a bit limited compared to its peers.
Moving into the most modern and clinically significant antiemetic class, these drugs are absolute game changers, particularly in oncology. They directly address that key mediator we identified in the gut lining, the massive flood of 5-HT released by cytotoxic damage.
These are the heavy hitters, the potent, highly selective 5-HT3 receptor blockers. Their mechanism is highly targeted. They block 5-HT action both on the vagal efferents in the GI tract and in the NTS and CTZ. They prevent vomiting caused by chemical mediators released in response to cell damage.
So precisely what happens in chemotherapy or radiation.
Precisely. And their side effect profile is fundamentally safer than the D2 blockers, correct?
Substantially. Crucially, they do not block D2 or M receptors, which means they completely avoid the extrapyramidal symptoms and the common anticholinergic side effects like dry mouth and sedation that plagued the older classes. Ondansetron is the name most people know, the prototype of the class.
Ondansetron revolutionized the management of postoperative nausea and vomiting, PONV, and chemotherapy radiotherapy-induced vomiting, or CINV. Its oral bioavailability is moderate, around 60 to 70% due to first-pass metabolism, and its duration is about 4 to 6 hours.
Which often requires repeated dosing.
It does. We've seen successive drugs designed for improved potency and duration, like Granastron. Granastron is highly effective, about 10 times more potent than ondansetron, and significantly longer acting, with a half-life of 8 to 12 hours. This longer duration is a major clinical advantage, often allowing for once-daily dosing.
But the true long-haul champion, designed specifically to tackle the most insidious form of nausea, is polonosetron.
Polonosetron is currently the longest-acting 5-HT3 blocker available, with an extraordinary elimination half-life of 40 hours.
40 hours.
This is why it received specific U.S. FDA approval for delayed CINV. This is the nausea and vomiting that commonly occurs after the first 24 hours, often peaking 2 to 5 days post-chemotherapy. Polonosetron remains effective for that entire period.
So what are the key limitations of the 5-HT3 antagonists?
While they are highly effective for chemically driven nausea, we have 2 key clinical notes. First, they should generally be used cautiously during pregnancy. Second, and crucially, they are not effective in motion sickness.
Right. If you remember our principle, motion sickness relies on H1 and M receptors, not 5-HT3. The mechanism just doesn't match the cause.
For the most intense, highly immunogenic, vomiting-like high-dose cisplatin chemotherapy, blocking the 5-HT3 receptor alone is often insufficient. We have to block multiple pathways simultaneously.
Combination therapy. This is where we bring in the NK1 receptor antagonists, targeting that very potent substance P.
Precisely. Aprepitant is the foundational drug here. Its mechanism is to block the neurokinin, or NK1 receptors in the CTZ and NTS. These receptors respond to substance P, which is released alongside 5-HT, as a powerful secondary immunogenic mediator.
It's the backup mechanism the body uses when 5-HT is blocked.
That's a great way to put it. Clinically, the use of aprepitant dramatically shifts the success rate of the antiemetic regimen. It creates a synergy that's indispensable in high-risk oncology.
How much of a difference does it make?
When aprepitant is added to a regimen that already includes a 5-HT3 antagonist like ondansetron and a corticosteroid like dexamethasone, it significantly enhances the antiemetic protection. Success rates jump from protecting 40 to 50% of patients to roughly 70%. This combination is the gold standard.
Speaking of synergy, let's discuss the critical role of corticosteroids, particularly dexamethasone, which is frequently used as an adjuvant.
Dexamethasone is often administered intravenously before chemotherapy, typically 8 to 20 milligrams. It is highly effective in alleviating delayed vomiting and synergizing with the other blockers.
But the mechanism is a bit of a mystery.
It's somewhat mysterious, yes. It's thought to involve its general anti-inflammatory effects and potentially its ability to potentiate the efficacy of the other antiemetics. It also helps manage some side effects, like the dystonic reactions from metoclopramide.
We also use agents like benzodiazepines, not primarily for blocking the nausea signal, but for managing the surrounding psychological factors.
Correct. Benzodiazepines like diazepam or lorazepam have inherently weak antiemetic properties. Their value is clinical. They're used primarily to sedate the patient, relieve anxiety, and most importantly, address the psychogenic component of anticipatory vomiting.
The vomiting that occurs just from stress before the chemo even begins.
Exactly. By reducing anxiety, they reduce the central drive to vomit.
Finally, let's touch on the highly specialized and controversial class of cannabinoids, exemplified by dronabinol.
Dronabinol, which is the synthetic form of THC, has demonstrated antiemetic activity against moderately emetogenic chemotherapy. Its mechanism involves acting through CB receptors on neurons in the CTZ and the vomiting center.
And its use is pretty limited.
It is. It's typically reserved as a second-line antiemetic when conventional drugs fail, or as an appetite stimulant in patients suffering from cachexia, like those with AIDS. The CNS side effects are significant hallucinations, dysphoria, sedation, and the high abuse potential means its use is generally restricted.
We started with the violent expulsion of emesis, moved through the strategy to stop it, and now we move to a quieter but equally vital area of GI pharmacology, optimizing what we keep down. We're shifting from motility and central signaling to chemical support aiding digestion and absorption.
This brings us to digestants. These are substances intended to promote the chemical digestion of food fats, proteins, and starches via enzyme or acid replacement. This is a pharmacology focused on correction rather than blockade.
Let's run through the key enzyme replacement agents.
For protein digestion, pepsin is sometimes used with hydrochloric acid in patients with gastric achelia or atrophic gastritis. Papain, a proteolytic enzyme from raw papaya, is available, but our sources express some doubt about its actual efficacy after oral ingestion.
And for starches.
We have diastase and tachodiastase, amylytic enzymes from the fungus Aspergillus oryzae, but again, their clinical efficacy is often considered equivocal.
The largest functional need for digestant replacement, however, is often linked to pancreatic insufficiency.
Absolutely. Pancreatin is the most clinically important and functional digestant we have. It's a pharmaceutical mixture of pancreatic enzymes, lipase for fats, amylase for starches, and trypsin for proteins sourced from hog or pig pancreas. It is used specifically in pancreatic deficiency states.
Like chronic pancreatitis or cystic fibrosis.
Exactly, where the hallmark is steatorrhea fat and undigested nitrogen in the stools.
And there's a crucial detail about how pancreatin must be administered for it to work.
That is vital. Enzymes are proteins, and the potent acid in the stomach will rapidly destroy them. Therefore, pancreatin must be administered in enteric-coated tablets or capsules. This protective coating only dissolves in the higher pH of the duodenum, ensuring the enzymes get released where they're needed.
Moving on, we tackle a common GI complaint gas and distension with a physical agent that works by changing surface tension, simethicone.
Methylpolysiloxane, or simethicone, is a silicone polymer. It's a purely physical agent, a viscous liquid that acts as an anti-foaming agent. It works by reducing surface tension, which causes the small bubbles of froth and gas to collapse into larger bubbles that are easier to pass.
Finally, we jump to an entirely different therapeutic area that involves chemical manipulation, managing gallstones pharmacologically. What is the context here, given that surgery is usually the standard?
Laparoscopic cholecystectomy is undeniably the current standard treatment for symptomatic gallstones. Drug therapy, bile acid therapy, is an alternative, non-surgical option reserved for a select subset of patients.
Those with small cholesterol stones who are either unwilling or unfit for surgery.
Precisely. The agent of choice is ursodiol, or ursodeoxycholic acid. It is significantly more effective and much better tolerated than its predecessors, which carried a risk of liver damage.
What's the precise mechanism of ursodiol's dissolving action? It sounds like it tackles the problem on multiple fronts.
It's a three-pronged attack to achieve solubilization. First, ursodiol reduces the cholesterol content of bile itself, which helps dissolve existing stones. Second, it promotes the solubilization of cholesterol from the stone surface, actively shrinking them.
And third,
Third, and most proactively, it inhibits intestinal cholesterol absorption, thereby reducing the amount of cholesterol being secreted into the bile in the first place, preventing the formation of new stones.
so it's both corrective and preventative. What is the expected success rate, and how long does the treatment take?
Our sources indicate that complete dissolution can be achieved in up to 50% of cases, but this is a marathon, not a sprint. It requires a long course of administration, typically between 6 and 24 months.
We've covered the entire spectrum of GI chemical regulation, from the explosive ejection of emesis to the quiet chemistry of digestion. We established the CTZ's role as the unprotected toxic checkpoint, and we mapped the pathways, the vestibular route with its H1 and M receptors.
Versus the chemically induced route with 5-HT3D2 and NK1.
Right. We saw the crucial functional distinction between central antiemetics and GI prokinetics, and recognized the specialized long-acting role of agents like polonosetron in managing delayed CINV.
The synthesis here is clear. Controlling vomiting requires a highly targeted approach that respects all these diverse signaling pathways that converge on the brainstem. The complexity highlights why combination therapy, like that powerful triplet of aprepitant, dexamethasone, and ondansetron, is necessary to block multiple lines of defense at once.
It truly shows the incredible sophistication and occasionally the danger of the body's own defense system, which brings us back to that crucial discussion of drug interactions.
Indeed. If we connect this to the bigger picture, we dedicated significant time to the critical cardiac risks of cisapride. We established that the drug itself was safe until its metabolism via the CYP3A4 enzyme was dangerously inhibited by other commonly used medications,
Leading to a fatal buildup, QT prolongation, and torsades de pointe.
This massive teaching moment about CYP enzymes and stacking risk raises an important question for you, the listener, to consider.
Given the critical role of CYP enzymes in metabolizing almost all pharmaceuticals, and given that many modern antiemetics, including 5-HT3 blockers like ondansetron and polonosetron, are also metabolized by CYP pathways, what are the clinical implications for combination antiemetic therapy?
Specifically, if a severely ill cancer patient is on a highly effective regimen that includes a 5-HT3 antagonist, and they contract an infection requiring an antibiotic like erythromycin or an antifungal, both of which are strong CYP3A4 inhibitors, what new stacked cardiac risks might arise?
Given the standing warning about QT prolongation associated with the 5-HT3 class, what level of cardiac monitoring must physicians maintain to ensure that the patient's life is saved from both the cancer and the unintentional pharmacokinetic interaction? That is your deep dive homework.
A perfect place to leave it.
Thank you for diving deep with us. We'll see you next time.